All right, so thank you all for hanging with us today. Just a quick reminder: every session is going to be posted online later, even the breakout sessions. So if you didn't get to attend one of them, they'll all be available on the website. Every on the main sessions in this room and all the breakouts. So for our last session for the day, before we get to closings from Jay, next up we have Ryan Howells on how to eliminate wasteful spending and manual processes with standards, and he's going to tell us all about how to stop doing stupid stuff. So Ryan, here we go.
So one of the best classes I took in high school was a class called Logic and Debate. Logic and Debate was an opportunity for us to be able to debate topics, social topics, moral topics, political topics that were very spicy. And a lot of the times, what happened is that we had to figure out ways where those topics could be to be shared. And one of the most life-changing experiences that I had in that class, and specifically in my high school career, was the idea of the teacher saying, I want you to choose a topic that is a topic that is core to your values, core to your morals. Like pick something that like there is absolutely, back to Kat's point earlier, there's absolutely no way that you're going to change your mind on that topic. So we chose one. After we chose one, she said, great, your assignment is to argue the other side of that topic. And I started like squirming in my seat, like I'm like, what? Like, no, the whole point was I'm not going to change my mind. Like I'm like, I go home, I'm like, telling my mom, I'm like, there's no way I'm going to do this stuff. It's crazy. It was the most life-changing experience I ever had because it was the first time in my life when I realized that there were other perspectives beyond my own that I need to respect and understand so that I can be able to think more holistically. If there's anything I could add to Kat's amazing presentation earlier, which I totally loved, the one thing that has actually changed my life more than anything in doing this alliance work that we've done for the last 10 years is the fact that there are really, I have realized, two types of people in the world, two major types of people. There are those that view life in a scarcity mentality, where there's a single winner and a single loser. So this is like in game theory, it's called a net zero sum game, right? So checkers, chess, basketball, these are all net zero sum games. There's one winner and everyone else is a loser, okay? And then those that view life in an abundant mentality and look for answers to difficult questions in the idea of, can everyone win? That is what's called a non-net zero sum game. And that non-net zero sum game, they're rare, but that is an abundant mentality versus a scarcity mentality. I will tell you, those that I have met in my life that are happier and more engaged and more outgoing and just happy with their life, they have that abundant mentality rather than the scarcity mentality. So today, what we're going to talk about is looking at things from a different perspective. Yeah, kind of funny topic. It's good. Let's stop doing stupid stuff. I named it that way because I don't know, maybe I just wanted to see if Jay would give me an opportunity to talk about this and Tina, and they said, yeah, sure, this sounds really cool. How many agree that we do really a lot of stupid stuff in healthcare? Raise your hand high. Very much? Yes? Good? All right. We're going to talk about these things. Now, here's my caveat. My caveat is some of these things I agree with, some of these things I disagree with, some of these things, it depends on the day. Like sometimes I agree with them, sometimes I disagree with them, okay? My whole point is to what Steve Jobs talked about, is to think differently about the problems that we are all encountering. Now, this is not an exhaustive list of everything, but the goal here is to try to figure out ways where we need to think about these things differently. As we talked about earlier, there's this concept that we have had these issues for a very long time. And I get it. There are really significant problems for why we haven't made faster progress. And there are legitimate issues as to why we haven't made faster progress. But I think one of the challenges I have, because I go to way too many of these conferences, is because I see all of you all the time, and all the same things that we're doing, is that we don't think about these things differently than we have previously. So my hope today is we do the fun little, stupid stuff versus smart things, is just for you to think about this differently. So first one up, by the way, you're gonna see all my AI generated art because I don't want to get sued by anybody. So this is kind of how we're gonna do this. But number one is, yeah, we got to kill the clipboards. Um, if you do the things that Amy, we do this, if all of us, we do the things that Amy talked about, if we could prove someone's digital identity, we could help them be able to aggregate and share their data. And we can be able to share their digital insurance card information, either directly from the health plan, directly to the provider, which thanks to Epic and others, like there's 1 million plus cards in production today that's actually doing that behind the scenes. So there's 1 million people a month that literally don't have to show their card anymore when they show up to the provider site. That's growing exponentially as more EHRs and others are going to adopt this. Did you know that that's literally just those three things alone will literally save hundreds of billions of dollars from the healthcare ecosystem? And not to mention the fact you're not going to have a mother with a concerned baby in your arms thinking to yourself what's going on. Just those three things. So let's figure out a way to kill the clipboard. I think that's a really cool idea. I think the idea is, how do we figure out a way to do it at scale so that others can be able to benefit from it? I don't know about you, but one of those frustrating things that I have happened is when I go to a doctor's office is they do hand you that clipboard, right? It's just tough. It's hard. We all experience it. And there's many that are out there. I know there's EHRs that have been able to do e-check-in and all that stuff. It's happening. But the concept is, how do we figure out a way where the stuff we do on a daily basis can affect our lives too, not just others' lives, but our lives? This is going to make our lives better too. What does that start to look like so it can become more patient-centric? Amy mentioned directories, right? Provider directories. We have this federated system of healthcare in the United States where we all went off and ran and just built our own directories. And kudos to Amy and her team and Dr. Oz for giving her the cover to do this. They're going to build one for the whole country. Now, I'm being honest. Many of you said, phew, yeah, good luck with that. You know how many companies have failed on that situation or that organization? We got to help, folks. We got to help. We got to help figure out how to solve this. There is no reason we need all these directories. There's just no reason for it. We can figure this out as a country. Now, they've got some incredibly smart people working on this stuff, but I'm sure that when the first version comes out, it's not going to be perfect, but we don't need everyone in the room to start throwing tomatoes at it. We got to figure out a way to say, how do we help them? How do we help them? What can we give them? What can we do? What can we help them with? Because this stuff is tough. It is hard work. How do we figure out a way to do that? Because at the end of the day, what's going to happen, and if those of you saw the Wall Street Journal article yesterday, I think it was, about Medicaid patients who have these ghost networks who can't find a doctor to be able to be a PCP for them because it looks like the doctor is there and they just won't accept Medicaid patients because of whatever reason. And so you've got all of these people suffering because of that idea that it's very difficult. So how do we figure out a way to help people get more access to the care that they need? So we can be able to choose that primary care physician and be able to figure out ways where that linkage can be happening at scale. How many hate all the password rules that you doing that? Yes? I'm on like this random website the other day and it was like, I don't even know I think it was like I don't know, like concert tickets or something like that. And they literally were like, here's what I want you to do. I want you to create a password that's 18 characters long. All right. I wanted you to do like alphanumeric, special symbols. Like, I'm like, I don't even care. Like this, I don't even have any, I'm not even giving you any PII data. Like, why am I doing this stuff? That just doesn't make sense. And so what makes sense is this concept of digital identity. Now, here's what's important about the digital identity piece. It's a choice. ID.me actually did a study one time and they go, how many people want a government issued ID? How many people want a private sector ID? And how many people just want to log in with their username and password to the individual portal? Guess what it was? 33%, 33%, 33%, right? The folks just want choice. They just want a choice. They just want to say to themselves, what can I do to actually make this choice to figure this out? Apple did some cool stuff this week. I think was when they released the new version of iOS, and I got mine actually last night. I don't like the liquid crystal display, by the way. I don't know if everybody's downloaded that yet, but like it's a little bizarre and the whole interface is weird. Anyway, that's a bad Apple thing. But the digital identity is where you can upload your passport, and it's a really cool interface. Like they do the selfie match, but they also do liveness testing. It's all biometric. It's all stored in the hardware of your phone. And now you can start to use that at scale. Now, it's interesting because I don't know what Apple's going to do, but if Apple decides that they're going to put authentication on that too, then it's like Apple Pay. You'll be like, choo-choo, boom, choo-choo, boom, on apps, on all kinds of different places. And it's all privacy preserving because the data is actually only the data that they need to actually log in. Two-factor authentication is your biometric plus the cryptographic key in your phone. That kind of stuff works at scale, which is really cool. We'll see what happens, but identity is super important for all kinds of reasons, both B2B and B2C, and so that's kind of really where we're moving. Information blocking, stupid thing. Here's the key point. Information blocking is happening everywhere. And what I mean by that, when I define information blocking, I know there's a legal regulatory definition of it. I'm talking about situations like I talked about a little bit on the panel before, where they're an organization that has that legal right or access to the information itself. So like a provider for treatment. And those two providers are saying, look, I am a provider in your region and I am treating Ryan at this hospital that's across the way. And I'm going to tell you that that I need access to to his information because he's now coming to my hospital for some reason. And the system says, no, we're not sending it because we're afraid that you're going to take that information and you're going to steal our patient, you're going to do whatever. We're just not going to send it. Now, I know that's a rare example, probably, but it's happening between them. We've heard directly from multiple health systems that happens today. Payers and providers, there's blocking on both sides, obviously patient access, there's other things that are going on. The point of this is to be able to say, this is incorrect behavior. We need to save people's lives by giving them access to the data that they need to make the decision, whether that's providers or whether that's even payers or whether that's patients. How do we make sure that happens? So we wrote this paper that you can look up, and we'd love to get your feedback on it as well. You can look up the information blocking paper that we wrote. It's real weedy, and it's in terms of policy. But the idea here is that the policy in the federal government actually doesn't work the way that it needs to make it happen. So the reason that we haven't had any enforcement on information blocking is because the internal gyrations of the federal workforce hasn't been in place. For 21st century cures, OIG was never, it was an unfunded mandate. So OIG had no funding to actually enforce information blocking. That was one problem that we had. There was literally dozens that had to be resolved inside the federal government before they could actually go and enforce some of this stuff. We're hopeful that some of those ideas, we did a whole deep dive on the regulatory side to see how do we actually try to fix them. And we want to leave it open to say what else needs to happen to make this actually work. One thing I will say, if we're going to solve this, we literally need thousands upon thousands of other examples that you feel could potentially be in that situation so that people can be able to start to share the data. We know there are organizations out there that have a policy to say we're not sharing the data under any circumstances. So what does that start to look like? And again, it's not taking a regulatory hammer to something. It's more about saying to themselves, there is a legal right to that information. How do we figure out a way to be able to send it? So I think sometimes we get caught up in the fact that this is a horrible, bad thing, but it is a good thing if we can start to get the data to flow. Revenue cycle management. Now, I was at a conference, I started talking about this, and I started throwing revenue cycle management under the bus, and the organizer came up and goes, Ryan, just so you know, one of our major sponsors is a rev cycle management company, and I'm not sure how they're going to handle this, that you actually talked about this, but I actually agree with you. You're actually right on this stuff, but I'm not sure if the sponsor is going to like it. So for those who don't know what revenue cycle management is, I'll just sum it up in this way. Revenue cycle management is the provider is actually owed a specific amount of money to do a specific set of services which they can't collect because the systems don't talk to each other. So they hire a whole bunch of people in order to track down the money they're already owed. One health system told me, ready for this? They have hired 1,000 people for just revenue cycle management, meaning I'm chasing money I'm already owed. This is a stupid thing. Now, you may be in that, by the way, I shouldn't have said this at the beginning. Take your organizational hat off and put it down for a second and just look at this from the objective of what you think is best for healthcare overall. And then I'd love to hear your feedback on it. Do you agree with it? Do you not agree with it? We'd love to hear that. But I want to put your organizational hat on, pretend like we're all independently wealthy, and let's figure out, like, are these the right answers? So in my mind, there's two things that are going to not necessarily solve the entire problem. But certainly the health system also told us that 30% of the time people walk in with no insurance card. And so 30% of for the 30% of patients that come in with no insurance card, they're physically trying to track down the insurance card so they know who to bill. We think digital insurance card is going to go a long way with the CMS-Aligned Network. We think the e-prior authorization stuff for 0057 is going to go a long way. For those who don't know, the early adopters have told us on e-prior authorization that 85% of the time the health plans are, they've been in production for 3 years, 85% of the time the answer that they get back is that no, a prior authorization is not required. So 85% of the time, in real time, they're getting an answer back and saying, nope, not prior authorization not required. 93% of the time, they'll get the answer back. It'll be yes or no, but it'll come back in real time. So literally by implementing 0057, we're solving 93% of the problem in real time, okay? Whether or not someone needs to do prior authorizations or not is a policy question for all the health plans that they're dealing with right now. They've made commitments to the administration. We'll see what they do. I'm just saying that even in the existing model, 93% of the time, they are getting an answer back in real time. Now, I don't know about you, but I don't know which provider doesn't want that. Like, that seems to be a good outcome. Same with the payers and same with the patients. I would love 93% of the time to get an answer back in real time about whether or not my prior auth was accepted or not. Now, we wrote this in our Kill the Clipboard paper in March. And I don't know, people started freaking out a little bit, but I think they're kind of okay now. I'm not exactly sure. But I think one of the biggest barriers we have to innovation right now is our CERT program. Now, the reason I say that is because the CERT program, Certified Electronic Health Record Technology, managed by ASTP-ONC, the Office of National Coordinator, under the HITECH Act, they certify electronic health record technology. Now, I'm going to be way overly simplistic about this, but what they do is they certify both functionality and interfaces. And they do a little bit of other stuff too. But functionality means I'm going to tell you how to build your system. Okay? Interfaces are literally interfaces that are between the systems themselves. Okay? What we're saying is, in order to unleash innovation both inside the EHR and outside the EHR, we think it's imperative that we figure out a way to actually certify just the interfaces themselves. I don't want to be telling EHRs any longer what to build inside their black box. That's their UI. It's their proprietary model. It's their workflows. They don't need to wait for the government to actually tell them what they need to do to build that. And they also, that means they can do more of their client requests that they're getting. They can build more of that into their product roadmap rather than waiting. What we're saying is we actually need a way to make sure that we certify the interfaces and try to redefine EHRs to be able to say, hey, let's just define them as an interface. That way, a provider has more opportunity, more choice, more ability to say, hey, I want to use my EHR for this. I want to use my cloud vendor for this. I want to use a vendor for this. But I want to make sure that when we do this, the interfaces are appropriate, because there's a lot of workflows that are non-EHR workflows to make that happen. So we'll see what happens, but that was a big thing. We think that that's a great opportunity, like I said, to unleash that innovation. So find ways, again, inside the EHR, outside the EHR. How do we find ways to do that? This administration's in a deregulatory mode. We'll see what happens. The other thing, I know we're super excited about AI. I get it. It makes total sense. I'm excited about it too, by the way, super excited about it. But I think one of the things I'm seeing online is, well, we'll just implement a MCP gateway and this whole thing's going to be solved overnight, right? This whole thing's going to be done. We're good to go, right? Model context protocol, if you don't know what that is, fine. But the idea is, oh, let's figure this out. This is good. We can move to AI before APIs. No, don't do that. We've got to get APIs installed first. That's the first thing we got to do, in our opinion. In my opinion, this concept of like, we've got to figure out a way to make sure we have the structured data in a modern architecture that allows for the data to be exchanged and interfaced in a common way. When we've done that, then we can have API-based clinical decision support for both the provider and the patient. That allows the models to be trained easier and faster and cheaper than they can be today. It's very costly to train these models, extraordinarily costly. And so if we want to have the value and the benefits of all of the stuff that AI has, let's see if we can move from APIs first and then try to move into to AI and figure out ways to do that. As it relates to clinical decision support, what does that actually start to look like? All right. Now we're getting into this real spicy stuff. All right, ready? Everybody still with me? Oh, no, we're going to get to reception. I promise. This is going to be good. Recently, the Trump administration officials actually wrote an op-ed that basically said no one should belong to CHAI anymore. If you guys know what CHAI is, you guys know what that is, the Coalition for Health AI. It was a group that was organized a while back, 6+ years ago or so, to be able to develop at the time. They were going to develop specific models where they could be able to test out to find out if the model is actually valid or not. They were going to go through this kind of idea of like, how do we figure out evidence-based models and how do we figure out testing the way that it happens? It got to be a little kind of political and related to what's going on because there were some folks that were involved in that. And so the administration Senate came out and said, like, you shouldn't do that anymore. You shouldn't actually be involved in this. In other words, we don't support this at all related to it. 2 of the 3 cloud vendors are actually now not in CHAI any longer. They're not doing it. But here, let me just, so I don't want to get into the idea of good or not. Let me just explain some facts. Facts number 1 is there is no regulatory agency or regulatory construct to actually oversee AI for the entire country. FDA does some stuff on devices, I get that. But for healthcare data specifically, even if we wanted to regulate AI, there's no actual regulatory pathway to doing that. Congress would have to pass a law to create a new agency or give an agency authority to actually oversee the AI itself. And so then the question becomes, would that even work in a generative AI environment, right? What would that even look like? What would the policy look like? How would you actually oversee it? That becomes very difficult. Now, the reason I said stupid thing, smart thing is because, of course, it's a smart thing to actually oversee AI. I think the only question is, where do you oversee it? Do you oversee that locally? Do you oversee that at a more of a state type regional level? Do you oversee that as a national level? That to me is the only real question. And all the smart folks that I've talked to is the idea that local control makes the most sense. And the thing that we're missing right now is we're missing some kind of a framework for how to actually oversee AI at a local level. What does that look like? So an underfunded hospital that is losing, someone told me in the hallway, they're losing $200 million a year, which is insane, but that is not uncommon across all of our health system friends out there. How do we figure out a way where they could be able to get the open source framework that they need to oversee AI as it relates to clinical decision support so they can extend their clinical staff? Another health system that I spoke to told me that in the next 5 years, they have 1 million patients that they serve today that will no longer have primary care physicians because they have no supply coming their way. They have too many patients, and the patients are obviously getting older, and they have not enough clinicians and doctors coming their way. So they said, everything that's coming at us right now, Ryan, is a headwind, whether it's HR1 or reimbursement. You start going through the list. Clinician burnout, I'm not going to go through the list. You know what the list is. But the idea is all of that's a headwind. So what is our tailwind? Our tailwind is actually interoperability, digital health, and AI. That is our tailwind, because we need that to supplement our current providers to be able to supply care to the million patients that are going to lose PCPs in the next 5 years. So they go, Ryan, I know what you do for a living. Interoperability was like 40 on our list. It was like way down the 40 or 45. It was like way down the list. He goes, it literally is now number one. And I'm like, really? And he goes, yeah, number one, digital health, interoperability, and AI, taking control of our data, running the models against it, and extending our clinical staff is the number one priority, even up to the CEO. I found that interesting because, as you guys know, much of the stuff we do is kind of behind the scenes, and a lot of the times we don't get that CEO level view of it. I hope more health systems view it the same way. I hope that we can be able to get the word out that this is an opportunity for us, but we got to do our job first. Who hates manual quality measurement reporting? Raise your hand, high in the air. Come on. HEDIS is not, NCQA is not in the room. Come on, bring it up. CMS is in the room, but that's okay. She's not in quality. So QRDA, PSV, if you know what these words, these acronyms mean, I'm sorry. I'm sorry if you know what they mean. They're crazy garbage things that we've done that is nuts. Let me give you an example. Amy won't throw anything at me, but she didn't do this. But 20 years ago, when they did the QRDA stuff for providers that are sending quality measures to CMS, it took them 7 years to actually get it to work in the first place. I didn't even realize that. There was no testing, nothing. 7 years. Maybe you guys have worked on that. But then it's like, now we still have it, but we have an API infrastructure that we're moving to, but we don't have a quality measurement infrastructure that actually supports that API infrastructure. So we've been working with NCQA and CMS for the last 3 years to say, listen, I know you are the quality measurement gurus on this stuff, but every time that we get together, by the way, in July when we got together with an Amy's party in DC, we said, what's the number one thing we should change actually as a group? What's the number one thing we should change? And every single one of them said quality measurement reporting, quality measurement reporting, quality measurement reporting. And so when we talked to NCQA and CMS, we said, listen, we have 2 data models in the country. We have USCDI v3 for clinical, and we have the Carrot IG for Blue Button for claims. Everything we do in the future have got to be built off those 2 data models. That's just the long and short of it, because that's what's going to be exchanged across the country. Can we figure out a way where we can be able to share that information and run the quality measures off those 2 data models? And we've been spending 3 years on this topic. Now, if you'd like to participate, let me know. It's great. But the idea is we're able to do it. Now, the good news is NCQA is a little farther ahead than CMS, a lot farther ahead. And we've run 75% of HEDIS off of just FHIR and CQL and run what they call digital content services. 75% of HEDIS is no human intervention. It runs straight through to NCQA. We're 25% of the way there of running complete digital quality measurement well in advance of the 2030 deadline that NCQA talks about. Now we got to work on the provider side and be able to get this QRDA thing mess out of the way, because we've got to figure out a way to do it that way with CMS to say, how do we send just the clinical data that's needed to CMS for MIPS and all the stuff related to CMMI programs too. We'd love to participate with you. If you're interested in that topic, it'd be great to talk through. All right, who hates data use agreements? Raise your hand. Oh, you all love data use agreements. Really? Oh God, you hate data use agreements? So this is a tough crowd, I guess. Everybody loves their data use agreements. That's okay. No good? No good, no good? So we're all, I view this as like a big kind of family, because we all know each other, because we'll show up at the same conferences. So there's so many of my friends and family that are working on this hard issue. So I'm not trying to be disparaging when I say this. But what I'm saying is I broke the glass in September, and no one has tried to re-put the glass together or yell at me on this stuff, which kind of makes me nervous. I don't think payment and operations is ever going to work on national TEFCA. And the reason that I say that is not because of any technical issues related to things. It's related to the fact that we have data use agreements, and we don't have trust between payers and providers. What that means is that we are in a situation where it's hard for payers and providers even to come into the same room. And for them to just close their eyes and say, I'm going to agree to the flow downs on the common agreement and share all my clinical data with you, payer, is obscene. Like, that's just not going to happen. At least in my lifetime, that's not going to happen. So because that's why they negotiate these data use agreements every 3 years or so and say, here is the specific use case when you can actually get access to the data. So that's where, in my mind, that's where the CMS-Aligned Network approach comes in to say, look, here's the endpoint, here's the provider directory and the endpoint payer directory, here's all the stuff, leverage the existing data use agreement you have today and just figure out how to do FHIR. I know it's point to point, I get it. We don't like point to point, we like network. But let's figure out a way to scale it from point to then networks. We're doing some work in Utah and 12 other states. There's a bunch of states that are in here to say, can we then do it at a state level? And then let's figure out how to do it nationally. While all the other smart friends that I've got that are in this room and other rooms are trying to figure it out nationally, can we start small? We talked about, B2B FHIR. Kat talked about that. Like, nobody's using FHIR. Well, if we can use it, at least to start here, we can then grow it in a better way. As I mentioned, we've been working with the Health Exchange on this in Utah. And I don't want to get anybody kind of depressed on this stuff. But we started 2.5 years ago meeting every other week with senior technical folks from each of the organizations in the state of Utah on the largest B2B FHIR pilot in the entire country under the governor's direction. The governor said, this is a priority for our state, and we are just testing. I'm sorry, but that's like where we are. We spent the first 6 months just getting everybody in a room talking about things. We then said, look, we need to figure out a way to get the endpoints back and forth. How do we do that? Where's your test environment? Oh no, I got to procure for something. Okay, let's wait for your procurement for 6 months. Like, it's hard. What we've learned from this is a ton, by the way. What we've also learned from this is the fact that we all got to actually get on the same roadmap for this to make sense. Last thing I'll say on this with e-prior authorization is providers have told us very loud and clear they don't want another payer portal. And interestingly, payers have said, we don't want you to use our payer portal. We just want you to use something. so go do something. And don't just basically stop calling and faxing us. I'm oversimplifying a very complicated issue. Stop calling and faxing us. So what do you want to use? You can use anything you want. Just use our business logic and figure it out. Well, the answer to that question, what we've learned at eHealth Exchange is they have a client-side app. They have a single user interface that's payer agnostic, and that ability is then sent to a HIE or QHIN to route that information to the right payer to then pull that information back so that the provider has that single user interface. A payer agnostic approach helps the provider, it helps the payer, and it obviously helps the patient get an answer back in real time 93% of the time. We've learned a whole bunch of other stuff, but I don't have time to tell you any of it. All right, before I do this last one, let me give you an analogy. 21st Century Cures, in my mind, put the gas on interoperability. It basically said we have moved from may share to must share. You have to share data now. That is required by 21st Century Cures, and you have to move to API-based data model. And then all of a sudden, HIPAA goes, whoa, hang on there, this person there. You got minimum necessary, you got all kinds of things, you got privacy and security, you got data use agreements, you got it, whoa, hang on, the timeout. Some would say that these are conflicting, others would say they're complementary. I could make an argument probably either way, but we do have a problem here in my mind. We have two statutes that were widely accepted and widely used that seem to somehow compete with each other in the marketplace. And that's going to become a problem. As I mentioned before, data use agreements is a massive, massive problem. One of the reasons that Amy's daughter can't get access to the records is the fact that those organizations didn't have data use agreements with each other. That was one of the issues among probably many as to why that data wasn't transferred better. You all know this. I'm talking to the choir. So then there was a survey that was done by Black Book Research around API data and interoperability. And in that survey, they asked payers and health plans across 39 states, what are the biggest barriers for implementing the APIs? 77% of them said contracting and data use agreements. 50% said data normalization and mapping. 40% testing capacity, 39% vendor bandwidth, and 34% unclear ROI. What's interesting about this is that that first one is directly related to HIPAA in the contracting issue in terms of how those things actually start to conflict. So, bold idea. What if we got rid of HIPAA? Now everyone's going to freak out. Oh, what did he say? I don't know what's going on. What if we just ditched it? Let me explain. This is literally from an article on a website. How can I get the best HIPAA compliant EFAC services? Are you kidding me? Number one, talk to Devin about this. There's no such thing as HIPAA compliance. You can be compliant with the privacy and security policies of HIPAA, but HIPAA does not comply. You don't get a HIPAA compliant. There is like beautiful like things that are on the websites that's just like, I'm HIPAA compliant. I know it's shortcut, I get it, but we have a misunderstanding of what it is. And then we're HIPAA compliant of EFAC service. So what do we do instead? What if we thought about this in terms of how do we protect the data regardless of who has it? And making sure that the data is protected in a way that uses HIPAA as a floor and not a ceiling. And so that we can find a way where we can build on all of the gains we got in HIPAA with privacy, security, and consent, but we can build it off of there and say, we can actually do more than that. As I talked about on the panel before, some of these individual access service providers, identity proofing, right? Consent-based ideas, the idea that the data is stored in the hardware of your phone, like they are competing on privacy, security, and consent. So what would that look like? It's probably a world I'm never going to live in because that's probably never going to happen, but it's something to think about differently in terms of how we think about data and where that actually, what that looks like. Oh, proprietary code sets. I got to go quickly. I don't like proprietary code sets. They're not really fun. Interestingly enough, Secretary Kennedy has mentioned the fact that maybe we need to go after the 266 million in proprietary code sets that we have today. I don't know what's going to happen there. It's really interesting, but AMA has granted, if up in the top right-hand corner, has granted CMS and its authorized agents a royalty-free license to use current CPT in both print and electronic CMS publications. That actually is a real document that really actually happened. So what does that start to mean? What could we actually do in terms of how we think about this in a different, changed way? I think this is my last one, but federal matching funds. Anyone in the Medicaid space here at all? All right, just really quickly for those of you who are not, the federal government matches for development purposes 90% of a state's cost for doing healthcare technology development projects. And there was a letter that was written specifically to one vendor, I'll let you read it on the screen, that actually said, listen, the 90% of the money that we're paying on these eligibility enrollment systems in Medicaid, it actually doesn't work. This stuff doesn't work. The eligibility stuff that we're paying for at a state level doesn't work. So 4 of these Democratic senators, I wish it was bipartisan, they probably just, I don't know what happened in the background, but this is a bipartisan issue. There are tons of states right now that are buying this technology, and the technology just doesn't work. It would be interesting to see if we could actually pay for technology that works. That would be really cool. And figuring out ways where we can pay for outcomes and not pay for just code. And I know that CMS is kind of moving in that direction. They have for quite some time, outcomes-based certification, but we'd love to see kind of more of that, I think, in the future. So let the debate begin, all right? Hopefully that was spicy enough. I've got about 3 minutes for any questions that you've got. Otherwise, we'll have a really robust discussion, hopefully, at the reception. Thank you. Any questions? Yes.
You talked about the certification of EHRs, right? Which very interesting topic. But even then, there are just a few set of EHRs that are required to certified. We're still missing behavioral health and post-acute care and whatnot. Do you think that the API-based certification you're talking about, could that take us to the next step?
So we did a webinar called Kill the Clipboard. You can look at it on Levitt Partners, and there's a slide at the very end of that webinar that talks about kind of our opinion of how all these things get together. TEFCA, HINS, CMS-Aligned Networks, how we think it could potentially be put together. What I would say is on that slide, we said everyone is a network now. What we mean by that is if you've got an endpoint and you can send and receive digital identity credentials, you're part of the network. Your payer, provider, patient, behavioral health agency, whatever you are. And there are multiple now examples of open source tools that you can use, and you can implement these things like that. Now, I know digital identity is not free, but the open source tools are. And so to your point about behavioral health, do we start a whole new behavioral health high-tech program that gives them all this money? Or do we say, use the open source tools that says, here's your FHIR endpoint and here's digital identity, you're now part of the network? I don't know, we'll see. I mean, we'll see what happens. But the concept here is that the barriers to entry have never been lower in terms of getting on the network. We'll see what happens in terms of real life. Other questions? Yes. This could be a hard one. Mr. Marchand, yes.
So Ryan, one of the things you talked about was the digital identity. I know that's a big thing for you and for Care Alliance. Health systems today, most of them anyway, run real-time eligibility. So when a patient's scheduled, they're checking eligibility. Help me understand how the electronic insurance card is better, different, changes that workflow than what they're doing with RTE today.
One is they're paying for it. Sometimes they're paying for it. Sometimes you're actually running through a clearinghouse. Two is all the providers may not have that functionality built into their EHR. I think that's another issue. Three is oftentimes the insurance company doesn't know where you're going to see, right? Which doctor you're going to see. If you choose a PCP during open enrollment, they can send it directly to the PCP and you're good to go there. But if you go to a specialist in 13 other states, you know, like Amy's daughter or others, they may not have that information so they can bring it along with them. And I think there's a lot of reasons for it. I think that the concept here is that you'll be able to have all of that information at the touch of a button or in your person so that you can be able to provide it if it is needed. And again, that hopefully over time, as we all implement some of this stuff, we may not need it, right? Which would be great, right? If I don't have to bring it because my doctor already has it that I'm going to go see, fine, that's wonderful. But could I upload it as part of an e-visit check-in to allow that to actually happen? That becomes the power of open standards over time and finding ways where we can take advantage of those to scale it. So I think we got time for one last question. Or we could just go right to the reception. Thank you, everybody. Appreciate it. Thanks.